Benson,
Hey, how are you doing?
good. How are you feeling today?
Good, good. Not bad. Nice to see you.
Likewise. Would you mind if I called on you on a slide to ask for your insights on a particular
Yeah,
topic?
sure.
Great. Thanks.
Morning.
All right. How you feeling, sir?
Good. How are you doing, Benny?
Not too shabby.
Good. So thanks for doing this and look forward to your presentation. Hi, Benson.
Our presentation. Yes.
That's it.
Yeah, the community presentations. Sri, how you doing?
Hi, Arlen. Morning. Hi, Benny. Morning.
Yes,
Morning.
sir. How are you?
Doing well. How are things with you?
It's a great Tuesday. The sun is out, which is rare around this time of year.
Good. How are things in Omaha, Sri?
Things are going well. It's getting a little colder. On the other thing that we are talking about, working with the two people that we
Good.
kind of interacted with. So it'll take off. The only thing is I have an overseas trip in a couple of weeks.
Yeah.
So I'm just kind of moving things along. It's after I get back that I'll kind of ramp it up. That's the plan.
Good.
Yeah. Thank you.
Yeah.
Okay, I'm going to try to test sharing the screen here.
So who is the host? Oh, it's strange.
I think I am. Let's see if it shares.
Looks like it's recording. Yeah, that looks good.
Good. Okay.
Yeah.
I'll stop sharing until everybody joins.
Yeah. So tell us a little bit about Benny. Tell us a little bit about what you're doing in Pittsburgh. What is your role there?
I was hoping to avoid the pomp and circumstance, but thanks for asking. So currently in Pittsburgh, I'm wearing three different hats. The first of which is a business consultant in the digital health space and the health AI space. And that's what's bringing in most of my living and food on the table for the family. Ancillary to that, I'm a candidate for the executive MBA program at the University of Pittsburgh, and we're doing a really cool AI governance research project, which should be the first real world case study on a business incorporating one through a maturity model. And then lastly, I'm building up a couple of startups, one of which is a health AI company for caregivers.
Good for you. So are you teaching on the faculty there or participating in some educational programs?
Participating, that's right.
Good.
Yeah,
And,
it's one of the only, I think one of only 6 schools that has an executive MBA program for healthcare.
Yeah.
So a lot of cohort and the people that I'm working with are providers.
Right. And what's the name of the school? What's the business school?
Joseph M. Katz Graduate School of Business.
Good. And is that part of an MD MBA program at the medical school too?
For some people it is, but I would say most of them are already established physicians. You have to have about 10 to 15 years of executive leadership, either in healthcare or in business to.
Oh, I see. It's an executive MBA program, so you sort of have to be out there a little bit.
That's right.
Yeah. We're often asked, should I get an MBA? And we've had this conversation several times, but from your perspective, where are you in the program now? Have you just started? And is it a 2-year program or a 1?
It's a 19-month. I'm about halfway through, and the ROI wasn't there for me. It certainly isn't. It still isn't. But it's a bucket list item I've always wanted to do and fill some gaps that, especially on the finance side, that I wanted to learn a little bit more of. So I think just like joining the military, you have to want to do it. It has to be something that you really want to enjoy doing. Otherwise, it's
So
probably.
it sounds like for you, and of course it's an individual decision, yet the ROI is not there.
The ROI it doesn't seem to be there. I could be wrong once I'm finished. Who knows? But
yeah,
it's more of a creature comfort.
And what was your
Yeah. I'm sorry, go ahead.
What was your Air Force experience?
I did 8 years in the Air Force, and I was in surgical services. So I did everything from anesthesia tech to surgical tech to L&D, central sterile supply. And so I learned a lot of great skills in the military, which afforded me a nice career afterwards.
And you were based at a hospital or at a battalion forward thing, or?
That's right. I was first stationed in Panama City, and then Cape Canaveral, and a few other hospitals like Luke in St. Louis, Luke in Arizona, and then St. Louis, Scott.
Were you in San Antonio?
For basic training, yeah.
Thanks.
I have a little bit of retrograde amnesia there, but thanks for bringing that up again.
Yeah. Morning, Anthony.
Good morning, everyone.
Hi, Dr. Chang, how are you?
Yeah, thanks for joining us. I think everybody knows Anthony from ABIM and other things, MI10, whatever. So it'd be good if everybody sort of puts in their contact information if you want to, whether it's LinkedIn or email, or some folks even put their cell phone numbers in, just so anybody that joins this thing can connect. So I'll put okay, good. All right, so it's 7 o'clock, so why don't we get started? I'm Dr. Arlen Myers. I'm with the Society of Physician Entrepreneurs, and thanks for joining us. This is the next in our series of modules on healthcare AI entrepreneurship, and we're pleased to have Benny Aspara, who is from the University of Pittsburgh, leading the session. So Benny, if you have any comments or chat items or questions, feel free to include them in the chat. We'll try to address them as soon as possible. And this session is on various aspects of AI, ethics, and risk management, amongst other comments. Just a reminder, these sessions are on the second Tuesday of every month at 7 o'clock Mountain Time. If you have not already registered, you can go into the Canvas site to look at pre-reading and other resources and other things that might interest you. So without further ado, Benny, take it away.
Thank you, sir. Thanks, everybody, for joining. I'm excited to start this conversation with you. Let me share the screen. Everybody can see?
Not yet.
Excuse me. All right.
Okay, so we can see something now.
Okay. A couple disclaimers. You may see a lot of AI generated imagery in this presentation. The VBA code was created by ChatGPT, but there was a really cool legal case that just went through that said that AI generated art cannot be copyrighted. So I took the liberty of doing the unethical and including a lot of AI generated imagery in here just for context. I am a proud member of SoPE. I'm grateful to Dr. Chang's here. I'm also a proud member of MIS. I am doing research at the Collaborative AI Responsibility Lab in the University of Pittsburgh, and I'm also a volunteer with Duke AI in the Chai group. And then lastly, I'm a consultant for health AI companies as they start to commercialize.
What's the Chai group?
Chai is a group specialized in developing guardrails for AI governance. So it's a collaboration between Duke AI, Mayo Clinic. I think, Dr. Chang, are you involved in that with Stanford as well?
Anthony, can't hear you.
No, but I think Stanford Nigam Shah may be.
That's right. Okay. If you haven't had a chance to skim through the pre-reading materials, they'll still be posted in Canvas. I think Dr. Myers had mentioned the purpose of this module is to look at the recent 2023 ignition of real meaningful legal, ethical, and risk management implications of AI in healthcare. I think that when we look at this in the discussion, we'll blend thoughts around health AI governance, some of the medical imperatives that are coming. I think Dr. Chang just mentioned Dr. Nigam Shah, who has really interesting thoughts around what healthcare AI ethics means right now. And then we'll also look at the business considerations. So let's get started with the latter. I did want to provide some context from an entrepreneurial standpoint. It's really interesting to see how the funding of health AI companies is coming down the pipeline. Right now, the IPO market is firmly closed. There are longer fundraising cycles for venture funds, and there's a slower deployment of funds, or the timelines are slower, so that the companies spend more wisely, which is really interesting. And so you'll see a drop off. It's starting to taper off and level out right now in terms of the investments going into the digital health space, but particularly health AI. Somebody was going to say something?
Yeah, I was just going to say that there seems to be a long tail. In other words, yes, what you're saying obviously is true, but there's some pretty big investments in artificial intelligence, and that seems to be where most of the action is these days.
That's right. That's right. I think what's really interesting, you'll see in the next slide, there are a number of health AI companies popping up, a lot of hype, but the adoption is limited to specific problems that need to be clearly identified in terms of value to healthcare. And so what we find right now is that when you look at health plans or healthcare systems which are adopting health AI, there's a reluctance to go towards or to adopt solutions that focus on one particular disease state or one aspect of a disease state. And they tend to want to find areas that have been traditionally failures in healthcare, whether it's women's health, population health, care management at home, and most importantly, making sure that the cost of the care is associated with an economic ROI. I think everybody saw the most recent purchase of Oak Street Health, that obscene $10 billion acquisition. So you'll see a lot more into provider operations companies. How do we optimize provider workflow? How do we mitigate burnout? How do we make sure that we're reducing that administrative burden? And so I think that when we start to think about health AI solutions and start to build them out as entrepreneurs, we find ways to make sure that they're closely aligned with the problem and problems that providers face. And then most importantly, at the end of the day, the venture capitalists want to know why. Why is it important? How is it going to provide us with an ROI and the healthcare system provide with an ROI? Any thoughts around this?
Yeah, Anthony, you recently sponsored and produced a meeting in Washington, D.C. with some healthcare executives. Given what Benny just said, do you have anything to add in terms of pain points or observations or resistance or adoption? Or any of that?
Oh, there are many pain points, but ethics is not yet one of them, because I think it's still pretty far down the adoption curve in terms of things that they're grappling with directly. But regulatory is certainly there now. So, and maybe it was just because I was in DC, but I think people realize that ethics is really important since that's the topic today, but they're not really directly confronting it right now.
Okay. And is it still your impression that most of the effort is toward financial and operational goals rather than
Yes.
clinical?
Yes.
Okay, thanks.
And adoption and education and trying to get a financial justification for adoption. But obviously the point is that there are plenty of non-financial dividends that you need to consider as well.
Okay, thanks.
To Dr. Chang's point, you heard, I think it was in the AMI conference, the Stanford AI and Medical Imaging Conference. Dr. Nigam Shah said that ethics means more than just fidelity to bias and data excellence. It also means, how do we look at fiduciary responsibility? How do we look at the greater good that AI can provide for a specific problem that we're trying to solve for? And to what point, when is good enough, as we start to look at that workflow in developing AI solutions in healthcare? This was a really interesting large language model report done out of NYU Langone, where they looked at 336,000 patients to predict readmission, mortality, comorbidity, and even insurance denials. And so I don't know if anyone had any thoughts on how we optimize AI responsibly in medical education, but also in improving the workflows in the hospitals.
So I think there are three imperatives. I call them rules, rights, and regs. So the regs have to do with primarily the industry responsibility and responsible AI and all that stuff. The regs obviously have to do with government oversight, primarily the FDA, although there are other government agencies like the FTC or the Consumer Protection Bureau or other SEC, other regulatory agencies that actually have oversight of part of artificial intelligence. And the third, and the rules have to do with what are the professional responsibilities. So how do we monitor and account for ethical lapses by doctors? And I've sort of kicked around the idea of the ethics committee, because most hospitals have an ethics committee that usually has to do with care ethics. But I would imagine that would start to include AI ethics as a subcommittee or as part of the ethics committee. But the problem is that the people on the ethics committee are not up to speed with artificial intelligence because they're members of, the faculty, and they're only as good as their education and practice. So I think we have a way to go in terms of how do we regulate internally? How do we monitor ethical AI practices in a hospital environment? And finally, there's the rights problem, which is what should patients know and what should the patient Bill of Rights include when it comes to artificial intelligence? So in the very beginning, you put up a disclaimer about using AI to produce this lecture. What's our responsibility to disclose to them how we're using AI to take care of them?
That's right. You bring up a really good opportunity that's afforded to us right now. You're seeing a trend towards a lot of these health systems having an interdisciplinary approach to how they process and govern AI. And I think, and obviously, Dr. Chang's a chief AI officer, and you're seeing a lot more interest into developing those type of roles, more so on the director side. But it's really interesting to see how these platforms are bringing them up. And I'll bring an example up later in the conversation.
Yeah. Is anyone else in the group have experience with this? Are you, or Anthony, is anything going on at Chalk or Benson, or is anybody dealing with like an AI ethics committee, or how's that work?
I decided that it's either me becoming part of the ethics committee or the ethics committee sends a representative to the AI committee that we're forming. So I think we're going to end up doing both, Arlen.
And in term, I know you're probably in a preliminary stage, but how would the process work?
In terms of an ethics issue,
Yeah. So if a doctor, I mean, how would you scan or implement the ethics process? Because right now, most of us are familiar with sort of, if I'm a clinician and I have an ethics problem, I mean, a typical one is end of life decision in the ICU. So if I'm and there are issues. So if I'm confused or the family's confused or I need some help, I call up the ethics committee and I say, here's my issue. What do I do? And I get like sort of a consultation. They obviously don't tell me what to do, but it's a self-reporting thing. It's not, oversight or surveillance on us at scale. Do you see the same thing happening with AI? Or if that's the case, my sense is it would be underreported.
well, I get a sense that in the beginning it will be very much of a case by case basis that we start to accumulate experience with, and then it'll be, I think, more streamlined. And I think that's why I decided that we would do it both ways, that we would have me going to the ethics committee and ethics committee sending a representative to the AI committee, because I think an open, transparent dialogue from the very beginning will be very key to have this domain be covered, since it's a very new domain, as you said.
Yeah. And Shri brought up a point that the ethics committee needs to include a data scientist or somebody that understands this a little bit deeper than clinician, if they're not already a data scientist. Do you agree with that?
Yes, absolutely.
Yeah. Okay. Well, great. All right, let's move on.
Yeah, one of the interesting results that is coming out of our research is we're measuring perceptions of employees of a health AI company, investors, and potential consumers of the health AI company. And Dr. Chang was absolutely right. We're seeing that while employees have a high level of interest in health AI ethics and using it responsibly, we're seeing that investors place less emphasis on those AI ethics, and more so they're interested in the regulation and the outcomes that come from that specific AI solution. And so you'll notice that there's a couple quotes that I received from these surveys where the health AI investors really wanted to bring home the idea that a lot of these companies and solutions aren't staying close to the healthcare problem they're trying to solve, or they're not necessarily aligned specifically with the provider. And so my colleague who's working with me on this study, Dr. Sam Wang out of University of Pittsburgh, he's the NLP chair for the American Health Informatics Association, has been trying to find ways to make sure that his algorithms and his research projects, are very much aligned with AI as an extension of the provider or as a gap stop for provider loss or kind of a decline in providers in a specific area. Any thoughts on?
So Benny, if I'm the chairman of the ethics committee at the University of Pittsburgh, and I created, or the university or somebody created an AI ethics subcommittee, and I ask you to be on the subcommittee, and you say, sure, I got to put my money where my mouth is. We just had a conference about this and I'm going to do it. And they say, great, send us your stuff. And you tell them that you're the founder of an AI ethics company, an AI company. And they say, well, that's a conflict of interest. So can you see that happening, or has that, because I've had that happen to me. It wasn't an AI company, it was a digital health company that I was trying to incorporate or pilot at my home institution. And they say, oh, no, that's a Stark law violation. It's self-serving. We can't make exceptions. You're on the faculty. We can't give preference to you. So I couldn't do it. So my point is, I think we need to rethink that industry organization interaction because it gets in the way of collaboration and moving the issue forward.
Yeah, I couldn't agree. And when we start to talk about the risk management, you'll see a contract that is becoming trending with providers to avoid that conflict of interest. Great point. I'll bring that up though. That's
Good.
really profound. Okay. Lots and lots of different types of biases, as I learned from the American Board of AI and Medicine's course. The ones I really wanted to focus on, which seems to be the most prevalent, are, at least right now in Q4, are those that are related to data excellence, whether it's not having the right IT infrastructure, the unstructured data is really bad, or having, more importantly, a small data set. I think someone had mentioned Mimic 3, where they had about 40K ICU patients out of a hospital in Boston collected and de-identified to provide to folks for a strong data set as they build out health AI models. What I see in health AI companies is that they want to make sure they have that continuous data validation, especially when they're looking at uncertainty quantification of the results or the output of that health AI, especially in conversational realms. There's a lot of algorithm bias in terms of GPT discrimination, exclusion criteria. And so you see a lot of health AI governance committees starting to look at how do we compensate for any discriminatory bias that's in the data set. There are challenges now arising with automation bias, where providers may be leaning heavily on GPT more so than they are validating it. So how do we have, if we're going to be using large language models, especially those general large language models, not healthcare designed ones, how do we have a physician or a governance fallback in that space? And then lastly, I think the one I want to really highlight, this seems to be a huge problem as we develop healthcare LLMs, is the hallucinations that come from it. And imagine a patient who's using GPT instead of going to a provider and GPT is diagnosing them with unicorn flu. It's just not, it doesn't exist, and it just causes problems in conversations between the patient and the provider. Any thoughts around bias? Did I miss any that seem to be the most prevalent? I know there's many, but I wanted to make sure I touched upon the big ones.
Anthony, can you address the issue of drift? I recently read something that when the large language model started taking MCATs, which is all the splash about how they were smarter than students that took it. But as they did it more and more, their actual pass rate dropped. So can you address what is drift and what are how do you prevent that, or what do you have to do?
Drift in terms of in the AI context is when you have changes in the demographics of the patient or a cohort or a methodology, or in this case, the content of the kinds of questions you get in the test that would not reflect the original statistical analytics of the project. So it's kind of like I draw the analogy to exploration of things like tires and cars, that the faster the car is moving, like in a race situation, the more likely it's going to wear out. So the more often you use the model, the more likely it's going to reflect a kind of a wear and tear of the model based on a long list of things. But it includes categories like the cohort that you're studying and the data that you have gathered, as well as the methodology of the test.
So you're an enthusiastic Formula One fan, and the solution to the tire problem is tire science. I mean, these people have it down to it. They got all these analytics, and they change the tires like whenever they have to, and they really know when to do it, which tires. So how do you do that in AI? I mean, how do you constantly change the training set to reflect the contemporary test set?
Well, you have to pay attention to it. But my solution that I think eventually is going to happen is you have automated tools built in to detect drift and then correct. I think it's going to be very demanding for humans to do it all the time with all of the projects.
Yeah, it sounds pretty impossible. I mean, it's got all this stuff. You can't just keep doing it over and over and over.
For humans, right?
Yeah, right. Oh.
Dr. Myers, you brought us something up interesting on the last slide, which was how do you compensate for conflicts of interest if you're trying to develop an AI governance model in your healthcare system while also being an entrepreneur in a health AI company. The International Association for Privacy Professionals is currently working on professionalizing AI governance. And so you'll see pretty soon here a certificate for AIGP that may help to satiate a lot of those bioethics needs in the facilities.
The other impact or consequence of this conversation has to do with accreditation. So, for example, if you're, undergoing an accreditation site visit or some standards accreditation, I'm involved sort of tangentially with some of that stuff, and the standards for creating AI oversight, in this particular case, risk management, ethics, conflict of interest, have yet or are in the process of being developed. So I think you're going to see more and more when you undergo a site visit. And for that matter, it might also have to do with residency reviews. I mean, if you're running a residency, we haven't even addressed the issue of teaching and education and medical students and residents and faculty and accreditation criteria and all that stuff. So I think there's a lot of balls in the air, and we're just going to have to sort of, as we go along, figure all this stuff out. And the site surveyors, I mean, the organizations that do these accreditation things are going to have to figure out how do they find accreditors that actually understand this stuff when it comes to marking up the company that they're supposed to accredit, or the residency review, or the residency they're supposed to accredit. So I think there's a much bigger impact than we realize.
Yeah, I would agree. I would agree. And I know we've recently touched upon just seeing that trend, but also the trend of compensating for bias in the algorithms. And this was a really neat study where they looked at healthcare costs in their algorithm, but found that it was excluding those patients in that subset that had social determinants of health, which had the highest costs. And so they remedied it by making sure that they tag those Black patients to increase the amount of support and utilization they had to decrease the costs through healthcare rather than exclusion.
And I might add that this is an opportunity if you're an AI entrepreneur or an AI entrepreneur consultancy. If the JCHO comes knocking on your door and says, we're going to do an unannounced site visit and AI is going to be part of our assessment, that's an opportunity to help the company prepare for it.
That's right. Okay, a lot of talk, both from investors, but also from leaders here in this AI space about making sure that we identify the problem first before we even start gathering data, which is the big heavy uplift. And so this was a really neat analysis where they looked at GI and hepatology as to where the big problems are. Instead of focusing on a specific passion point, where can AI make the most difference? So I wanted to leave it open for discussion. Dr. Babu or Sri, have any ideas as to where the biggest problems in healthcare lie that AI can compensate for?
Or to put it another way, what problem are you facing that you would like AI to solve? Whether it's, again, I mean, we're focusing on clinical, but it could be operational, it could be process, it could be financial, it could be, thanks for joining us, Anthony. It could be whatever. Do you have any, Maria, you're teaching this stuff. What problems are your students trying to solve?
So thank you very much for asking me, and I'm just looking at it from that perspective because whatever the conversation I'm having in the course, it's a asynchronous course or online. So they are using AI at a very preliminary level, and they are not delving deep into that. They're either practitioners or clinicians in any of the capacity, surgeons, physicians, internal medicine people, nurses or pharmacists. So they are not looking at that from that perspective. But this intersections really nicely with another course I've been asked to teach in another university. And right now I'm just thinking about it. How much data, because my perspective is coming from educator, and I would like to ask you all those things that with the conversation that so far we had, they are at a really high level, like committee level, committee leadership level, or executive level, and those things. And you're inviting me to comment on this slide. So right now, since I am not a clinician, I do not work as a clinician. So I am looking at through my students' lens and the people around me who use AI. And I can only give you that much regarding that piece, but I can give you other things for educators if you're interested, or ask you more questions about that as well.
Yeah. Shri, do you have a response?
Yeah, no, just to build on what Benny was saying and sort of alluding to this slide, the two major issues that I see and hear are, where does this fit in my daily workflow, number one, and number two, how do I trust whatever output I'm getting from use of any AI tools, even though I don't completely understand what the tool is doing for me. So those are the two things that I hear and see all the time.
Right. So I have proposed this something I call a quilt set. You probably maybe have heard me talk about this in previous conversation, but so I'm thinking, what do doctors want out of this? I'm talking about doctors in the trenches. What do they want out of this? And this kind of amplifies what Shri just said. So I came up with this acronym of a quilt set. QWILTSET. So a quilt means, if you ask a doctor like me or anybody else on this panel, what do you want AI to do? What's the job that needs to be done? And my response is, well, whatever you give me, I would like it to improve the quality of what I'm doing in terms of patient care. That's hard to measure. But everybody's, I mean, in most instances, healthcare professionals value quality, either rightly or wrongly, incidentally, over experience, service, access, convenience. Those are patient values. Actually, I think convenience care trumps quality care. And we're seeing that as a result of retail outlets. That's what they're leveraging because it's an experience economy. So, and I think that's a problem because there's a values gap between the providers, unquote, and I know everybody hates providers, but the healthcare professionals and the patients. They use the experience and service as a surrogate measure of quality. And everybody knows they're not related. So that's an issue. But anyway, most of people in healthcare say, I want it to improve quality. So that's the Q. The W is, to Shri's point, which is workflow. I've been doing this a long time. The typical refrain goes, I've been doing this a long time. I do things the way I do it because it works for me. I have a certain workflow. I prescribe 5 drugs 80% of the time. I do this on a fairly rote basis. Don't screw up my workflow. I don't want to have to look at an iPhone to figure out what's going on. I don't want to have to go to 17 apps. I don't want to have to start switching screens. I don't want to have to, and do not give me big data. I want actionable information at the point of care. Don't dump a whole bunch of stuff from the Internet of Medical Things and, every 2-minute or second blood pressures for 1,000 patients. Not going to work. So that's the workflow. The I is what's in it for me? How do I get paid to do this? I'm seeing my salary going down. I'm seeing reimbursements going down. I'm seeing private equity squeezing me. How do I make money doing this? And why should I do it? I mean, what's in it for me? I mean, I get the big picture, better patient care, professionalism, mission, all that other stuff. But self-interest is a pretty strong motivator, if that's not the most important motivator. So what's in it for me? That's the I. L, so QWIL, and that has to do with what Benny described as, don't get me sued. I don't know whether I can trust this stuff. I don't know whether if I use it, somebody's going to sue me. I don't know what's going to happen. How do I deal with this? I don't know even whether my malpractice covers it. So I'm concerned about, and this sort of relates to the trust issue, is I'm not so sure I want to use this if I don't know whether this is going to get me sued or not. Because God knows I'm already doing enough stuff that's going to get me sued. What is it? 60% of doctors get sued by the time they're 50. I don't want any more brain damage than I already have. So that's the L. So QWIL, and then the T is probably the most important one, which is time. And the time is not, I want time to see more patients, because everybody's already seeing enough patients. They're burned out. I want time to spend more time with the patients I already have. I want more, and more importantly, or as important, I want time to do stuff that has nothing to do with medicine. I want to spend it on me. I want to spend it on my family. I want to spend it doing what I want to do and not burning out, spending all this time seeing patients and doing email stuff and doing, patient portal, pajama time, and all the other stuff. So that's the T. Then the set is, what are the social, emotional, and technical jobs that need to be done? Does it solve the problem I'm looking at? That's the technical one. But there are social and emotional issues as well. If I use this or don't use it, how am I going to be deemed by my colleagues? Am I going to be susceptible to social contagion, either good or bad? Is this going to meet my emotional needs? Because at the end of the day, doctors, just like everybody else, buy emotionally and justify rationally. So if I have a fear of using this, how do I overcome that fear? And there's lots of reasons why you might fear it. Or I want professional recognition, or I want to be cutting edge, advanced, key opinion leader, subject matter expert, out in front, building my personal brand, doing all that stuff. So there's a lot that goes into this. And I don't think, the final point I'll make is that technologists, I was recently asked, I'll give you an example. I was recently asked to be a participant in a podcast from a guy who runs an AI technology consultancy. He's a data scientist. And he said, and I said, well, I'm not a data scientist. I'm not a techie. I'm a doctor. I happen to do this stuff. But he said, no, that's why I want you to talk. So I said, okay, I will present what basically I just said. What should technologists know, or what do doctors wish technologists knew about artificial intelligence and its application to taking care of patients? So I sent him a mock-up presentation, and I got this thing back that basically said, this has nothing to do with what our technology audience wants to know. So I said, I don't think I'm such a good fit. And I referred him actually to some other folks, some of whom are on this call. So my point is there's a lot of folks between the data and the doctor, and we have to close that gap. If we're going to create mutually expectations, not only we have to trust the people. This is about trusting people. It's not about trusting a technology. So if you're not gonna play nice together, and you don't want to hear what I have to say or listen to what I think doctors are encountering, this isn't going to work. And I don't want to waste my time, frankly. So I said, here's some other folks that might be able to help you that can speak to the technology issues. So Harvey, you've been on this for a while. What are your thoughts about what I just said?
No, I agree. Today I was on Fox News talking about this same issue. Basically, the article is just going through that we don't have enough physicians and AI people like us, and we don't really know as much as Dr. Anthony Chang does. But the fact that we know more we can make some changes that are needed in healthcare. And the fact that we're both clinicians, we can see the problems from the inside, and I think that's what makes us very effective.
So Ty, do you want to give us your 2 cents?
Sure. I mean, it's worth what you pay for it. So, I mean, one of the things that comes to mind, I'm going to come at things from a sideways angle here. But we've been recently watching The Social Dilemma as part of, with my teenage son, like, do we give him access to social media? And so kind of reminded of all of the harm that came with social media. And then Tristan Harris, and I've really kind of rediscovered his Center for Humane Technology. And he's got a list of all of the downside harms from social media. As they talk about in the documentary, there's a lot of upside benefit to social media where people have been reconnected over the years. I mean, we're all hyper LinkedIn users and whatnot, and kind of see the benefit of social media. But at the same time, there's a reduction in attention, mental health. And so I think it'd be interesting to have a clear-eyed view, almost like a failure modes and effects analysis or hazards analysis around maybe the downside risk of AI, because it seems like a lot of the AI algorithms that were trained in, say, like Instagram, had been optimized towards basically like click attention and all of that. And so I think on a similar level, I think now we've got a much greater prevalence of AI that's being used in much, large language models. You've got the implicit, like racist bias that comes from the training in those models. And so I think it's like there's a bigger, broader discussion around like the downside risk we need to protect against in that. And so like, Benny, in your presentation, you've talked about some of those big risks, but I think it'd be fascinating to have just kind of a, documented, here's the, great things, and then also got the downside risk that's maybe more of a published, view of things, so that we at least understand the landscape of what we need to avoid so we can responsibly use it going forward. So anyway, I'm just curious if you'd seen anything like that, or, I mean, it seems like you're sketching that out, Benny, but yeah.
Yeah, no, it's a great segue into, so you bring up a really good point. I mean, so much related to AI, so many different types of AIs, and so many risks involved in building consumer and provider trust, to Dr. Meyer's points. And so with that, I'll bring that up. I'll bring that up. Perfect segue.
Can I just lead your segue into the next section?
That was amazing.
Great.
I'll try to burn through some of these, but from the legal perspective, there was a lot of what Dr. Meyer said echoed in a keynote speech by Congressman Murphy out of North Carolina, who's the only practicing surgeon in Congress who has some very interesting thoughts about AI in healthcare. But one of them, which mimicked what Dr. Myers was saying, is that it shouldn't be governed and regulated by the agencies. It should be regulated by healthcare and the providers. The AI needs to stay close to the providers because they're the ones who, this isn't like a generative AI tool that you would use to create some image. Rather, it really impacts that patient's life. And so the provider needs to be the driver of that AI tool. And so what we're seeing a lot of in not only data lifecycle, but also the consequences of not being fidelic to that data and its use. I think I was pretty gobsmacked by BetterHelp being fined almost $8 million for sharing data with vendors, which is quite easily done in the internet world with generative AI, but in healthcare, you don't do that because there's a lot of privacy and confidentiality issues involved. What you're seeing in the legal landscape is that America's backing off. European Union had an amazing AI Act that really took some heavily regulated requirements for medical devices because they are considered high risk. But in AI, in the United States, there's so many different applications and different types of AI that it's being deferred to the providers and to the healthcare systems. I think only 10% of the federal laws were passed, one of which was the National AI Initiative Act, which largely just boosts AI research and activities into agencies rather than regulating them. And then a lot of the laws were done on the state level, but most of them were largely around civil intellectual property or contract laws. And so we're seeing, while some people may view it as slow progress in legal regulation, others may view it as an opportunity for healthcare to take control of their governance at the local level, specific to the AI algorithm they're trying to employ, which may require different regulations and guardrails than a different type of AI regulation.
And at the same time, a significant, I think it's like 80% of people don't trust the government or industry to regulate themselves.
That's right. That's right. Okay, so I'll fly, just for the sake of physician entrepreneurs, I'll fly through a couple key considerations here from regulatory landscape. The White House, I love this time right now in AI governance because you have a left-leaning White House that's very individual-centric, very patient privacy, patient protection, and then you have the right-wing Congress that allows for that innovation to take control of itself and regulate itself. So there's like this almost balance of power going on in AI regulation. But what we're seeing is that the Federal Trade Commission is, I don't want to say taking control, but they may be the ones that oversee generalistically AI governance solely from the perception of their deception policy. So in other words, you may have seen the FTC get together with Google and Amazon, and they all made pledges of how they were going to use AI responsibly. In a certain sense, it was ethics washing. It wasn't really strong commitments. And the reason why I didn't make strong commitments is because they could expose themselves to the risk of being in violation of the FTC's deception policy, claiming that their AI could do something that it's not, or claiming that they're being responsible in the governance of their AI when there's gaps. And so you'll see a lot of joint statements come out from the Equal Opportunity Employment Center, the Department of Justice, talking about AI ethics, but all of these guardrails and guidelines are just me too, this is what it should be. They're not really actual pathways to AI governance. So I'm going to provide a couple of examples of what that looks like. A lot of FDA approvals, I think Dr. Myers had mentioned, most of them are in the radiology space, proven disease state, proven practice, for AI. Cardiology is next, and endocrinology is a far third. But there are pathways in CMS to look at AI from the lens of authorization. This is the most profound statement that I could find to summarize the current state of AI law and regulation, is that it's so diverse. The applications in healthcare is innovating so rapidly that no government or agency can really regulate us in a meaningful way. But there should be some type of guardrails and guidelines for healthcare to do it themselves, especially at the local level. And so I'll give examples of that. Excuse me. Okay. Risk management. From a data lifecycle, I'll just burn through this data lifecycle thing. From an industry-specific perspective, HIPAA and high trust are kind of the gold standards as to how you should function from a privacy data fidelic way. Process specific, you have TCPA, CAN spam, and then you'll look into comprehensive types of data life cycles. Like in California, you have the CCPA, and in Virginia, you have the VCDPA. Don't ask me what they stand for, but they're very comprehensive in terms of how you manage that data throughout the life cycle of the AI development. So really cool resources for you to reach out to. The governance piece is very difficult to look from a healthcare perspective or from a physician entrepreneur standpoint of how do we get to the NIST standards of AI governance. It's so broad and so high that there's really no journey from A to Z. And so we're going to talk a little bit about maturity models to help us get there. And I think obviously Dr. Castro is an expert in this space, but a lot of the tools that are out there for physicians in developing these AI models, or even utilizing them immediately, are starting to be self-declared as safe LLMs, whether it's Google's MedPalm 2 or I don't know, Dr. Castro, if you wanted to touch upon these as well, but Hippocratic AI is one that claims to have a very safe representative data set. Any advice on those new tools for rest management?
Yeah, I haven't seen or been able to play with Hippocratic AI. I just been whatever's on their web and press releases and I can find. It's very limited. But I'm anxious to see that, you know, given they just got about $50 million, another investment for them a few months ago. So I know they have the bandwidth to create these tools.
That's right.
The Google announcement, my understanding is that is a tool that is internal. So it aggregates data within an existing health integrated delivery network. So instead of just having a certain amount of information on the electronic medical record, it pretty much generates and populates the result from other data sets within the organization. It does not reach out to the internet or the web or whatever. It's a way to aggregate. So it's essentially a search engine for the electronic medical record and other things that might not be in the electronic medical record, but are useful at the point of care. Now, whether all that translates into what I call a reduced burnout impact factor, because the hypothesis that everybody is working under is this is going to reduce burnout, streamline workflow, and make doctors a lot happier. I'm not convinced that that's a valid assumption. And it goes back to your point, Benny, of what is the emotional and workflow impact of all of this? Does it really reduce burnout, which according to the latest 2 days ago analysis is going up, not down? I call it burnflation. It just keeps going up. So I don't see how any of this is really at this point yet making a difference.
So that's a really good segue into this, because here's the positive I wanted to bring up at the end of this conversation. While there are a million Me Too guidelines and guardrails, everybody's wanting to get their voice out there just like as we are, which is great. We're starting to see some places like Duke AI and Chai, and even I'll plug myself into finding ways to ensure that there's a practical application of AI governance in the development of your health AI systems. And so they're based off of the NIST guidelines, which is the gold standard, but they also stage us in that direction. And so I'll start with Duke's. Duke has a really interesting model they call the algorithm-based clinical decision support model. They have a number of committees that review a provider's or physician entrepreneur's idea for an AI algorithm. They look at the problem it's trying to solve, to Dr. Meyer's point, a workflow issue or optimized care. And then throughout the course of the development of that model, from gathering the data set to scrubbing it, to validating it and testing it, there are a series of gateways where each of the committees gets together to look and govern and see, are you guys tracking towards that fidelic way of developing these AI models in a safe and effective way? And this is becoming a really gold standard for a framework for a lot of healthcare systems to employ. The director of Duke AI Health, Mike Pacina, had mentioned that even as we develop this framework, we consider that may not be necessarily applicable to every healthcare system. So they need to deploy their own specific framework for their own types of patient populations and algorithms. But at least it's a good benchmark for people to work with. And the most important piece that they bring up is that there needs to be a clinical owner from A to Z. And that's where obviously Dr. Myers, you're stepping in, Dr. Chang stepping in, Dr. Castro, to develop these physicians who not only are passionate about healthcare AI, but also understand what it takes to sell it into their healthcare systems.
I would point out that there's a lot that goes into end users making technology adoption errors. So this is a piece of that, and it's interesting because I have formulated this as the ABCDEs of technology adoption errors. And without going into the gory details, you can Google it in the articles on the internet, but essentially it's about attitude, bias behavior, cognition, denial, and emotional reasons for buying. And we all know that doctors either accept or reject a technology or a shiny new object into their therapeutic armamentarium for very irrational reasons. And so while this is useful, and I can get into the details of all this, but probably don't have time, but the point is, while this is useful in the adoption, like the validity, you're basically trying to determine, is it safe and effective? But that's a very minor part of the psychology of technology adoption. And when I say technology adoption errors, it's like statistical positive and negative predictive values. So in other words, you're supposed to do what you're supposed to do, and you're not supposed to do what you're not supposed to do. But not infrequently, in fact, fairly often, doctors don't do what they're supposed to do and do what they're not supposed to do. Those are technology adoption errors. And there's a whole lot that goes into that. So while I would applaud efforts to kind of standardize this and make some sense out of what are the criteria, in my experience, it is not a predictor of appropriate adoption. And I think that has to be validated.
So yes, from a perspective of investors, the data that we're seeing in our research backs your claim up. I think from the perspective of potential consumers, we're seeing a different perspective as to the meaningful use of these type of frameworks. And I'm going to share a little, this had more to do with frameworks that providers use within healthcare and their healthcare LLMs. I did want to leave you guys with a case study that we're doing on an AI governance maturity model in the corporate side. So if you're a physician entrepreneur who wants to build out a health AI company or a startup, we're looking to find out what the perceptions of the potential consumers, the employees are, and the investors, and how they relate to the business impact. In other words, does it contribute towards adoption and growth in the market? Does it contribute towards competitive advantage against other either traditional behavioral health methodologies or other behavioral health companies? And what we're finding, to Dr. Myers' point, is that investors don't care as long as it's effective and there's some clinical evidence to back it up. We're seeing that employees care the most because they want to make sure that they're building a product which is safe for their customers. And potential consumers kind of change with their age. In other words, some of them care very deeply about the risks that they face with utilizing health AI tools. Some of the populations don't care at all because they want to solve the problem that they're facing. In this case, this was a health AI company that utilizes an AI virtual assistant for conversational cognitive behavioral therapy for insomnia, to treat insomnia. And one of the things we wanted to do is, okay, the employee perceptions are showing that you guys care deeply about AI responsibility and consumer risks towards the purpose of building consumer trust and further adoption. But how do you continue to improve? Where are you in the stage of your AI governance standards? And how do you improve towards the NIST standards? And so we're at the same time publishing an AI maturity model that takes them from beginner stage of AI governance to continuous improvement in their fidelity to data, simply for the purpose of making sure that they're building consumer trust. Because at the end of the day, adoption is related to consumer trust in health AI. And so really great and very insightful information that we're gathering from this, and hopefully this will be a good standard for health AI companies as they try to build from the direct-to-consumer market.
So Benny, how are you addressing the expectations of the different stakeholders in design, development, deployment, dissemination, implementation? So for example, self-insured employers are fundamentally looking for ways to reduce their cost. Doctors, as I mentioned, are sort of focused on quality. Patients are primarily focused on convenience and access and cost. Companies, particularly large companies, are focused on shareholder value. So how do you reconcile? And that's the challenge of doing any of this in sick care. You have all of these different values, and you have to create a value proposition that satisfies all of them.
Yeah, no, it's a great question. I'm going to share some experience bias here. So take it with a grain of salt. But what I found in my commercial experience is that the employer space is difficult. It's a 3-year sales cycle for any specific type of technology, certainly for health AI. And it's not guaranteed. It's those employee benefits are the first thing that they cut if there's an economic downturn. The second thing is they always complain about the payer should be paying this. We're spending so much money on insurance for our employees. So that would lead you to go straight to the payers. When you're looking at healthcare systems, obviously, if it's a home care device like this, they're going to say the payer should pay for this. Maybe we'll pay for incremental use if we're trying to get patients out of the hospital, decrease length of stay. When you look at the consumers, same thing. This company started out in the direct-to-consumer space to start to commercialize. But the consumers, and the reason why there's not been rampant adoption is because the consumer says, I have insurance, they should be paying for this. And so the point I try to make is that for a 2-year sales cycle, it's best to just start with the insurance payers and develop some really strong value-based models for your health AI so you could demonstrate the ROI for that payer space if you want to move forward quickly. That's my own experience bias.
Yeah. And the investor experience would tend to back that up because 2/3 to 70% of the seed money are going to B2B models, not B2C models. I mean, that's a B2C model is a tough gig. So that's what they're putting their money where their mouth is. And finally, to Sri's point, biopharma and med tech are already rethinking the medical specialty liaison role. And they're really trying to reconcile all of this between the key opinion leaders in the company. So we are already seeing a transformation of the MSL role and the sales role, particularly after COVID, when everybody was used to face-to-face and now they're doing it virtually. So that's kind of already happened. So we're out of time. Benny, great presentation. Thanks a lot for all of your insights and those that participated. And we'll see you next month. Thanks again.
Everyone.
Bye.